Okay, we're going to get started here because there's a lot to do, and it's about noon, maybe a couple minutes later, and welcome everyone. Okay, so let's see. This is the second session on the series of addressing difficult topics in aging and disease. This one will focus on mental health disorders, crisis disorders, and as well as depression. And as you know, that we are in partnership as we are the East Texas Geriatric Education Center Consortium, funded by HRSA. We've been doing this for quite a long time. And we partner with the Texas Area Health Education Centers, or AHEC East. Okay. You have lots of handouts. There's all kinds of materials that I'm briefly going to go over just to review some things. And you also have this as part of your handouts for your slides that should look something like this. Okay. And this is the agenda for today. We have two major topics, as I said, and in between we'll have a little bit of a break so that we could have cookies, I think. That would be nice. All right? Yeah. We're not going to have a lecture in this series in March, mostly because of spring break, and it just interrupts with those events. But our next one is going to be in April, focusing on cancer, screening and overdiagnosis, treatment options, surveillance post-surgery, as well as symptom end of life. And this is going to really highlight what we're doing with our CERSIT cancer grant, okay, that you'll learn much more about. In May, we're going to look at modeling long-term care, mostly in terms of nursing homes as well as older inmates in the prison system.
Okay, so my name is Dr. Lee Grumbles, and I want to just kind of explain a little bit why I was chosen and decided to help with the crisis mental health screening. Over the last few years, even though I'm a hospice doctor, I'm palliative medicine. And what is more important in dealing with our mentally ill elderly is the fact that we look at them at all levels. They're not just a physical disease. They're someone who's suffering with psychological issues, social issues, and spiritual issues. So I've been integrated and self-taught, as well as mentored by many of the area psychiatrists who work with these people on a regular basis. And I also worked very extensively with the probate court here in Galveston County during Judge Gladys Burwell's tenure. So I'm not an expert, but I have a lot of practical experience. So that's what we're going to do today, is concentrate on the practical experience that I learned, that I was struggling with, trying to make decisions, trying to know who to call, trying to know what to do, to try to take and give you a little bit of that information so that when you're put in one of these challenging situations, you'll feel comfortable knowing what to do and how to take care of a mental illness crisis. I want to take and introduce the people that will be speaking with us today and working with us. One is we have a standardized patient actress here, Miss Ruth Finkelstein, a talented actress, and she will be portraying with us during some role-playing a distressed daughter whose father is having a mental ill crisis. The other person I'd like to introduce is Dr. Lee Emery. Dr. Lee Emery is a geri psychiatrist. She works at Mainland Medical Center Institute for Living, and that is our closest area geri psychiatric unit. So we work very closely with Dr. Emery and with her colleagues over at Mainland Medical Center there in Texas City. And lastly, we have a special guest today. I invited Sergeant Kevin Walker, who is one of Galveston County mental health deputies, to come tell us really what he does, because you're going to see as we work through this class today, networking with your mental health deputies and officers and your MHMR hotlines, which have access to the mental health officers. That's a very, very important part of what you're going to be learning to do. Unfortunately, Sergeant Walker is going to have to leave early and not be here for the whole presentation. So to make things work today, what I'm going to do is have him come up, and we're going to let him present the information that he was going to be presenting kind of scattered throughout the presentation. We're going to kind of present it as a block. But what we're going to do is when we go back and start through the whole presentation, I'm going to be referring back to the information that he's given you, so you'll really kind of get the flow of what he's saying when we use use these different type of warrants and detention orders. So I'd like to introduce Sergeant Kevin Walker from the Galveston County Sheriff's Office.
Just as the doctor said, I'm Sergeant Kevin Walker from the Galveston County Sheriff's Office. I've been with the Sheriff's Office for 14 years. Grew up here in Galveston, right down the street. UTMB used to be a big playground for me, and now I'm part of UTMB. What we have here is a picture of Galveston County mental health deputies and a couple of officials one official with the Gulf Coast Center, which is a good picture because we have 3 of the original mental health deputies that actually started the division back in 1974. The very first sworn mental health deputy in this country is Mr. Mike Winburn.
Wow.
He's now the director of Gulf Coast Center. Then there was Captain Booker T. Joseph. He was second or third. He was in that first group. And Mr. Wayne Cook. He's also one of the very first mental health deputies for one in the country. We have Major Tulamondo. He's over our division. He's our bureau commander. We have Lieutenant Jaime Castro, who actually runs our division on a daily basis. We have Deputy Stinson, mental health deputy. We have Brenda Hughes, who's our admin assistant. She's not a mental health deputy, but without her, we wouldn't be able to function as smooth as we do. And we have Deputy Chris Howell. That picture's gonna change over time as we move up and move on and promote out and retire. So next year it may be a different picture. Hey, who are your mental health officers? Mental health officers could be anyone in law enforcement. It varies from county to county. Each county runs their mental health divisions different from one another. They're very similar. They have the same goal, and that's getting the consumer the help that they need, but they run very, very different. In Galveston County, the actual mental health deputies is the ones I just showed you before on the previous slide. We handle all mental health calls. And sometimes we get, not necessarily backlog, but some calls in holding, and the PD takes them to the hospital for us, and then we meet them there or follow up afterwards. But take, for instance, in Harris County, our neighboring county, I believe it's Precinct 1 constables. They actually do all mental health patients in Harris County, which if you've been in tune to the news within the past year or so, that responsibility is about to be shared with Harris County Sheriff's Office, is about to be shared with the Houston Police Department. So they're beginning to get more help as needed. In order to become a mental health deputy, there's several training classes that you have to take statewide and some national-wide. And of course you have to successfully pass examination to be qualified as a mental health deputy, and you have to maintain certain classes throughout your career as a mental health deputy in order to even maintain your license as a peace officer. Because some of our first line, most of the time our first line police officers, they are the ones that come into contact first with the patient or consumer, and then they contact us. So they have to be trained just like we do. So, but they normally call us, and we come and take over the scene or take over the call from there and get the patient to the hospital where they need to go. We service you name it, all over Galveston County. We go into water with Coast Guard. We have Coast Guard bring them to us, fly them to us, boat them in to us. Dickinson Bayou, wherever the patient is, we go. And you'll be surprised some of the places that we've been to take patients to get help they need. How does the commitment process get started? Well, of course, it gets started with someone, as the slide reads, distraught. And they're not always distraught. Some of them are cycling through their illnesses or what have you. Some may just not be coherent to where they're at, date and time, what's going on, or in place and stuff like that. Here in Galveston County, we work 98% of the time on warrantless apprehension. We use what is called an emergency apprehension detainer, which EAD, as we refer to, and it's a quicker process. And then having to detain the person, go before a judge with documentation asking for a warrant. By that time, we could have already had the person at the hospital and medicated. So 98% of the time, we use the warrantless arrest. Again, our neighboring counties, Harris County, 98% of the time they use the mental health warrant, which for them is a quick process for them also, because they have judges available 24/7 sitting behind the desk waiting and working. As in Galveston County, we don't necessarily have that. We have judges that are available to us 24/7, but they have shift work that in Harris County because of the population, to where they're able to do the mental health warrants. And it, like I said, it works the same. It's just here in Galveston County, it works much better for us and for the patient to use the warrantless arrest. Most of the time, when we're dealing with geriatric patients, we're going to use an EAD because at times the patient has given up or don't want to see the doctor, and you know they go willingly, you know, but we don't want them to get there and change their mind, you know, and once they get there and change their mind, you know, you have to do everything to legally keep them there. So to avoid that, we go ahead and complete an emergency outpatient detainer. So in case they change their mind about receiving treatment or talking to a doctor, we're able to legally detain them so they can get the help that they need. Because most of them a lot of them are in denial. They don't feel like they need help, or you know, their mental illness are causing them to believe that they're okay when they're really not. In most situations like that, and see where it says a risk to themselves or a harm to others. You know, we come across some cases like that, and in some cases they're not. Some cases they're just not making rational decisions. We have some of them that go out and give all their money away. They give all their food away, you know, and they feel like they're helping society, helping their neighbors, but then when you go back in their home, they have nothing. They've given everything away, so that's not a rational decision. So we come along and we see these things happening and say, okay, we have to get them help. We have to, you know, either they need medication, the medication's not working, or they hadn't been taking the medication. So when dealing with the elderly, it's hard to get them to understand that, you know, what you're doing is helping, but you're hurting yourself at the same time. So this is where the EAD comes into effect at. We get them to Mainland Medical Center, excuse me, and we complete an EAD. They mostly deal with Dr. Emery, which is the best, hands down, the best. And they get the help that they need at Mainland Medical Center. Sometimes from Mainland Medical Center, they're transported to Austin State Hospital to get further help as far as treatment and medication and whatnot. The EAD is good for 24 hours from the time that you sign it and sign the time on it. That 24 hours gives times for the doctor for them to be seen by a doctor, for them to detox if necessary, for the doctor to make a decision if they need further evaluation, which that 24 hours turns into 72 hours for the doctor to forward commitment paperwork to probate court. And it all starts with the mental health deputy's EAD. So our EAD has to be very thorough, it has to be complete, it has to be accurate, because this is what the doctor has to go on when they start their assessment. Versus, I mean, you know, if say the patient's cycling and they get to the doctor, which we had this happen before, by the time they get back to the normal side of the cycle, all the doctor has to go on is his EAD. They have nothing else because the patient is not displaying any abnormal, not displaying any mental illness at the time. So we have to be very accurate when we write this down, complete an EAD on any person at any time. Any questions?
In the clinic, I get calls from distraught children.
Yes, ma'am.
And what do I do? And I always tell families, it is not normal for your aged loved one to be harming you or themselves or anybody else in the household. And then I tell them to pick up dial 911 no matter where they are
Right.
in Galveston County. So I was glad that you covered that, City of Galveston has resources.
Right.
I know, of course, the Sheriff's Department covers the unincorporated areas of Galveston County.
Well, as far as mental health, we cover incorporated and unincorporated.
Okay.
So
And
we
we will make sure that you have your numbers. Instead of just having to call 911 before you leave today, we have a slide that has your different county and city contacts. I called all the sheriff's offices and the MHMRs and made sure I had the correct phone number. So at the end of this class, you're going to have the numbers that you can put in your contacts to be able to know
Right.
exactly who to call to get straight to whoever is triaging to send out for mental health officers.
and our number rings after hours and in the holidays and weekends. It rings straight to dispatch. So you will get someone. There's no automated anything. You get a person. Yes, ma'am.
Is your service unique to Texas, or do other states have something similar?
It is very unique. It is so unique that we get calls from all over the country of people that are starting their own mental health division. We got a call from Florida week before last of a chief in Florida who's starting his own mental health division and is asking us how to basically give us a blueprint on how to get started. As I go around the different training courses throughout the state of Texas, I listen to other stories and the things that other officers have to go to basically pick a patient up and take them 2 blocks to a hospital. It's unbelievable. So as far as our system of what we have going, I think is the best.
Do you have a business card? You're an excellent speaker for groups.
Thank you. I'll grab it right now.
Okay.
Yes, sir. Yes, ma'am.
About how many patients would you say that you have in this area?
We have 15,000 documented. If you look around since Hurricane Ike, you'll see all the Florida, South Carolina, North Carolina license plates to Washington, D.C. license plates. Those people came here in search of work, of rebuilding, and while they were here, they ran out of medication. They didn't have time to go to the hospital, go to the doctor, and we were getting calls from Key West, Florida, all the way to New York. Can you find my husband, my brother, my wife, my sister? So 15,000 documented, probably see another 6,000 to 7,000 undocumented.
I have a quick question, Sergeant Walker, about the adult children of our seniors, and maybe this is just an APS call. But let's say they're in their aged parents' home and they're taking advantage of them, or they're dealing drugs or alcoholic or something like that. Would we call upon your office for that, or?
Yes, you can, but our office is.
It's an abusive situation for the senior.
Right, yeah, yes you can. Not that our office deal with that, but I would never tell you not to call our office. So yes, call us for that. And we can get APS going, or we can, make a call to APS. We can go out and do a welfare check and, hey, this is unsafe, this is unsafe for the elderly, we need to get something going, get something going to help this person out. So yes, ma'am, you can call our office. Thank y'all.
Okay, well, like I said, I'm going to be referring some to what Sergeant Walker has told you as we go through this. So I want to just very quickly talk about the 3 objectives we're going to look at today. As a participant, you're going to be able to perform a brief mental health screen over the phone so that if a distraught family member calls you, you're going to know what you need to do the screen and to make decisions on who to call, okay? The second objective is before you leave out of here, you're going to have your contact numbers for your mental health deputy, mental health officer, or your MHMR hotline. And as Sergeant Walker alluded, it depends on the county and the city that you live in who you call. So we're going to try to help give you that information so that you'll know. And lastly, as a participant, before you leave, we want you to be able to understand and be able to explain to a family member the difference between what we refer to voluntary and involuntary admissions to a psychiatric center. And this is very important because lots of times the target people, the primary care physicians, the social workers, the home health nurses, they are the people who are still in contact in that first 24 hours, and the family are asking a lot of questions. So we're going to make sure you have some basic answers to questions that families would ask you. Now we'll just make sure everybody knows a little bit about our mental patients. Mental patients, are they dangerous, violent, likely to participate in criminal behaviors, and should they be locked up in hospitals? What do you think, yes or no? No, I think uniformly we would say no. And we have lots of reasons why we support that. You know, one of the major reasons is that putting people who are mentally ill in an institutionalized environment usually will worsen their mental illness. What we do is we may need to place them in an institution to institute or to titrate treatment. And once they reach a stable condition, we need to try to integrate them back out into a community setting. The other thing is that there is research that tells us these people with mental illnesses are no more dangerous, nor are they any more likely to commit crimes than people of the general population without a documented mental illness. So this is definitely an absolutely false statement. Another thing we hear people, another myth we hear all the time is, well, mental people are crazy because it runs in their family. Absolutely false again, okay? Mental illness is not something that develops from bad upbringing. It is something that we believe congenital and or hereditary plays a part in. But it's not that you had a rough life or an abusive family, dysfunctional family relationships, and that precipitated your mental illness. You know, mental illness are disorders of the brain. They are a disease process, and we need to treat them with the same medical respect that we treat diseases such as diabetes, ischemic heart disease, liver disease, lung disease. Our mental health illnesses are no different than those other diseases. They're just affecting the brain and the mind. Another myth statement that's out there a lot is mental patients do not have the same emotions as sane people. Somehow we want to put them different from us. We want to isolate them. We don't want them associated with us. That's not true. They feel the same emotions that we feel in the patients who don't have a mental illness. It's just that many times their ability to cope, to interpret their emotions, to express their emotions, it is abnormal. It's exaggerated. It may be inappropriate, but they are feeling emotions, and they do have emotions. One of the things that we commonly see in healthcare providers, whether it be nurses in a nursing home, nurse aides in the hospice setting, social workers, physicians, is many times when we're dealing with a patient who is mentally ill, we talk over them. We talk to their family, to their surrogates, to their guardians. And what we have to realize is those people's emotions are being negatively impacted when we do that. We need to treat our mentally ill with the same degree of respect that we would treat the person who comes into our clinic for a diabetes follow-up. Now let's switch a little bit about elderly people. Elderly patients suffer from mental illness sometimes that they are unable to understand the severity of their illness. They have a mental illness and they are unable to realize how debilitating and how problematic and how unsafe this mental illness has now placed them. They also sometimes may refuse to take their prescribed medications for many reasons. For intolerance to the side effects that the medicines occur, for a fear of paranoia or delusions that the medications may be somehow negatively impacting them. There's lots of different reasons why our elders may refuse to take their prescribed medicines when they're mentally ill. Another is that they're unable to recognize the need for medical assistance. I can tell you that Dr. Emery and I have been on the phone for this last week. I've already had to send 2 patients over to her for that exact reason. The people did not recognize that they needed medical assistance with their mental illness. And so we had to start through this process that we're talking about today. And lastly, a lot of the elderly patients suffering from mental illness sometimes are unable to recognize their unsafe or unhygienic living conditions. I remember teaching a young geriatric fellow one time, and I told him, I said, we're fixing to go into a home, and it's a home that I'm working with APS, Adult Protective Services, on, and we're fixing to actually have the patient taken into Mainland Medical Center, Institute for Living, for evaluation because they're in such unsafe, unhygienic conditions. And he kind of looked at me and thought, okay, and he climbed in my little car, and we drove over to the patient's house, and we got out. And this nice little house, it had a nice little manicured lawn because somebody was paying the lawn boy to come make sure the lawn was taken care of. And we walked through the door, and I said, get ready for it. And I opened the door, and the stench of human urine and feces, cat and dog urine and feces, and the scattering of the cockroaches throughout the house when the light from the door opened up into this dark cave-like house. I walked in, and all of a sudden I realized my young geriatric fellow was nowhere behind me. So I go back. It's like, okay, the patient's okay. They're in the back of the house. I say, I'll be there with you in a minute. I got to go take care of him, you know. So I go back, and he's on the front porch, and he says, I think I'm fixing to get sick. And I said, well, throw up, and when you get through throwing up, come on in so we can do the job that we're supposed to be here to do. So the issue is many times these elderly people do not see that they are living in unsafe and unhygienic conditions, and it requires us intervening on their behalf. Now, let's just talk a little bit. How are patients with mental illness portrayed in our popular books, our newspaper articles, our television, our programs and movies? Can you think back about some of the examples you've seen in the media and how media portrays these people? Is it
Criminal Minds, really?
Criminal Minds, exactly. Criminal Minds is an excellent example. They're always portrayed very negatively. They're usually portrayed at the very extremes. The little patient I just described with the scattering cockroaches and that are the mentally, criminally insane that have some type of severe, bizarre mental illness, those are the extremes. We don't see those in real life every day. What do we see? We see the little lady living down the street that has 6 newspapers sitting in her front yard, and you're realizing, gosh, she's not coming out and reading her newspapers. I wonder what's going on. Or when you're at church talking with your best friend, and your best friend says, my dad is giving me so much trouble. I don't know what to do. It just seems like every time he picks up the phone, he's got another crisis going on in his house. I'm wondering if he should be living by himself anymore. That is the patients we're talking about, not these vast extremes that really don't show up that often. Now, this is something that we just have to learn what's politically correct, and it's how do we refer to these people. And we want to say a person has a severe mental illness, not they're mentally ill. What we've found in research is that people with mental illness feel the term mentally ill when we are referring to them is derogatory. Now, to me, I don't understand that. I don't see it as a derogatory statement, but I'm not one of those people suffering from mental illness. And so what we've found is if we can learn to choose the right word choice and refer to this as an illness, it goes back to what we were talking about earlier on another slide. This is a disease. This is an illness. It's not a defect in them. It is an illness that they have. So the word choice helps us to build a trust bond with these people and be able to get them the help they need by us being careful with the word choice that we refer to them. Now, what we see many times is that loved ones may try to help. You know, I stop by the house every day and make sure mom's got clean clothes and mom's got, you know, her medicines. And Every morning I call Dad and tell him, make sure and take your pills. I filled your pillbox Sunday. Make sure you're taking your medicine. Or I go buy groceries every Wednesday and make sure the refrigerator and the cabinets are stocked. Loved ones do everything they can usually to try to help these people as they are edging into mental illness, which gets to the point where they deteriorate, where they can't take care of themselves. But there are times that even the watchful eyes and efforts of these family members are not enough. And it's not the family's fault. The majority of families are well-meaning in taking care of their elder, mentally ill patients. Okay? This illness is something that they as families suffer through as much as the patient is suffering through. And so what becomes a stumbling block is that sometimes the only alternative is to seek the legal assistance to care for someone that they care about with a mental illness. And that's what we're talking about today. We're talking about how do we help the distraught loved one, friend, significant other, spouse, who calls and says, I've tried everything to keep my loved one safe, and it's not working, and I need some help. And this is where we're talking about how do we legally move in to try to get that patient some help. Well, as Sergeant Walker talked about, his job as a mental health officer is to know how to evaluate a patient and try to decide, is that patient truly mentally ill? And if they are, is their mental illness decompensated to such a state that they need legal action to be taken to ensure that they get appropriate psychiatric and medical care? And this is a good list of the mental illnesses and warning signs, but the most important for us to make a decision whether it's crisis and something legally needs to be done is from 9 to 12. Are they thinking or talking about suicide? Are they delusional and are having hallucinations? Is there self-neglect going on in the home? Or is there unsafe behaviors that they're exhibiting? Or is there violence toward neighbors, toward their loved ones, toward children, toward animals, pets? Those are our 4 big red warning signs that if a family reports to you one of these last 4 are occurring in their loved ones, you need to be talking to them about, is this a crisis mental health issue? And you need to be doing this screen for us to try to realize, do we need to intervene on a legal level? Now, as we said, normally what we do here in Galveston County is we call our little 766-2323, and Dr. Walker or Jaime, or they pick up the phone on the other end of the phone, and I say, hey, I've got this problem going on, and I tell them what's going on, and they say, sure, Dr. Grumbles, we'll go out there and assess. And if they agree with me, they take the patient, and usually these guys are wonderful. They can literally, when I can't talk the patient into going to the ER and seeking care, they are so good at this, they usually can convince the patient that they need to go with them without handcuffs, without being hogtied and thrown in the back of the police car. They're able to get them to the emergency room for assessment. Now, Sergeant Walker told you about they're highly trained. And most of what I'm teaching you today, if you notice, it's not referenced. The reason it's not referenced is I am using the Texas Commission on Mental Health Officer Training and teaching you a lot of the basics that these mental health officers are actually trained. So they're trained at a high level of assessment, evaluation, and intervention. Now, why are mental health providers doing mental health screens? Well, what we have to realize is not everybody who's emotionally disturbed is mentally ill. There's lots of people who are emotionally disturbed and they don't have an underlying mental illness. But then the people who have mental illnesses, when we're interacting with a mental health screen, they usually do have emotional instability and they are emotionally disturbed at the time that we're assessing them. So here's something that's kind of important to look at when we compare and contrast these assessment for what's mental illness and what's just emotionally disturbed. And the big thing to understand is that in the mentally ill person, they will have behaviors that are inappropriate. They are very inflexible, and they tend to have lost impulse control. They're very impulsive. When we deal with someone who's emotionally disturbed, they're having the same emotional, psychological reaction to the situation that you or I would. It's just, it's exaggerated. So it's not that it's inappropriate, it's that it's extremely exaggerated. So when we're talking to our elders, it's important to understand, are we dealing with someone whose emotions are so wound up that they are exaggerating and having difficulty with coping? Are they really inappropriate with their behaviors and their thought processes? One of the things that they teach the mental health deputies to do when they go out is to look for the cues which suggest that a person is exhibiting symptoms of mental illness and not just emotional distress. And there are verbal cues, there's behavioral cues, and there's environmental cues. The verbal cues are usually illogical thoughts, delusions, sometimes hallucinations. Many times they're unusual speech patterns that they say, my loved one's not talking the way he normally did. The speech could be very pressured. He could be using words that he didn't used to use. He could be using cursing, inappropriate language, sexually oriented language that's like, that's not dad, that's not mom, they would never have said that before. And then there's extreme and inappropriate verbal and physical hostility that can come out of these patients. So we look for these verbal cues to try to tell us that it's not just emotional distress, it's actually an underlying mental illness. Then there's behavioral cues. These are people that we look at their physical appearance. Is their hygiene not up to par? Are they disheveled? Do they have mismatched clothes or inappropriate clothes on? We watch for body movements. Are their movements spastic, abnormal gaits? We try to decide, are they responding to voices or objects that aren't there with auditory or visual hallucinations? We notice, is there a lack of emotional response? We've talked about the emotionally distraught. Some of these people are to the point of severe apathy, sometimes cataplexy, and they have no emotional response. Another is, are they causing injury to their self? Self-mutilation is not uncommon in the mentally ill. And lastly, the behavioral cues is, are we seeing inappropriate emotional reactions? Not exaggerated reactions, but inappropriate reactions. Lastly, with our environmental cues, what kind of things do we look for when we walk in the house? Okay, decorations. Lots of times these people will be obsessed with certain decorations in their homes. And you'll think, this is a person that hoards shells, because all they have is shells all throughout the house. I had one little lady one time that all 12 months of the year, her house was filled. You couldn't walk with Christmas decorations. She had every kind of Christmas decoration, and it was this compulsion that she had for it. And then we've already given a great example of the waste matter when my geriatric fellow turned and ran out and wouldn't go into the house behind me. When we see that waste matter, it's a huge environmental cue to us. And many times we see an attachment to childish objects. You walk in the house and you start looking around and you say, this looks like these are things a child would be interacting with and engaging with, but yet it's an elder adult. So those are some of the environmental cues that we use. Now, one of the things I want to stress is, and this is something that we really are careful when stressing with our mental health officers, is we need to be careful to be culturally sensitive to things that we are seeing that in our minds seem bizarre and inappropriate, either in behavior or speech. I'll give you another example to try to hit this home. When I was a third-year medical school student, I was rotating in the psychiatric unit. And there was this lady who was from Haiti, and she believed in voodoo. That was her professed religion. But it was a very odd mixture of Catholicism and voodoo. It wasn't straight Catholicism. It wasn't straight, she wasn't a straight voodoo priestess either. It was this mixture. And I walk in and the nurse is like, she did it again, well, it wasn't Dr. Grumbles then, it was student Dr. Grumbles. And I said, did what? She keeps urinating in the trash can, and then she goes and gets the toilet paper out of the bathroom and she dips it in the urine in the trash can and she wipes it all over the door frame. And I said, well, what else is she doing? Nothing. Then she goes back to bed. I said, what, is she screaming and hollering or not? You're giving her commands. She's able to follow commands. She's easily directed. Yeah. Is she eating okay? Oh, yeah, I just take the food in there and she eats okay. But she doesn't want to come out the door. And she constantly says she's got to have urine on that door frame. Well, I thought that was weird. So I didn't say anything to her about it and went and did my little medical student evaluation. And that night I called a friend whose parents were missionaries in Haiti. And I was telling her about what was going on and how odd. And she said, you know, that's not odd. And I said, it's not? And she said, no. She said, you either take pig's blood or pig's urine and you put it on your door frame, and that keeps the bad, spirits from coming in on you. So she's protecting herself. She knows something's wrong, and she's trying to keep those bad spirits away. And it was like a light bulb went off in my head. I thought, oh my goodness, this lady, yes, she's mentally ill, but what she's doing is appropriate for her culture and her religion and her belief system. It's just an exaggerated method of doing it, but it's appropriate. So I went back and got an A for my 6 weeks of psychiatry because the psychiatrist was so impressed that I had figured out what was going on. And we treated the lady, and she was able, after about 3 or 4 more weeks, to be discharged from the psychiatric hospital and go back to take care of her 3 children that were living here in Galveston. So that gives you a brief history about what mental illness is, what we look for to see if we're in crisis. Now what I want us to do is I want us to role play a scenario. And the scenario we're going to role play is with Miss Ruth Finkelstein. It's going to be a Miss Margie Evans. And Miss Margie Evans, I've been taking care of her father, Bill Green, for several years as his geriatrician. And I knew his dementia was rapidly worsening, and I knew that some of his behaviors I was getting kind of concerned with. And I had told her I was concerned someday we may find a crisis where we have to look at taking her father out of the home where he was living and adamantly that he was going to live by himself. And we might have to look at a more safe environment. And so what we're going to role play is the crisis moment where that actually happens.
Oh, Dr. Grumbles, I am so happy you returned my call. I don't know what to do.
And, oh, Margie, calm down. What's going on right now?
Well, it's Dad. It's Dad. Okay, let me back up. I thought everything was fine. You know, Luke goes over to his house. Luke, you remember, he's my
That's your
7-year-old.
your 7-year-old son, yes.
My grandson, that's right. He goes over to Dad's house sometimes after school. Luke stays with me until his mom picks him up. Well, today he went over to Dad's house, and Dad told him to call me, that I had to come over right away because the spacemen were coming. And Dad has now locked himself in the bathroom, and Luke says that he has a gun, and he won't come out. I'm over there now. I'm there now, Dr. Grumbles, and I can't get him to come out of the bathroom. He won't even talk to me through the door. He keeps screaming, they're coming, they're coming.
Okay, now, Margie, do you think he's safe? You said he thought he had a gun?
He has a gun. Dad's always had guns. He got rid of most of them years ago, but he keeps a handgun in the house because it just makes him feel macho. But it's okay. I mean, I took all the bullets away. I've taken out all the ammunition. I don't think there's any bullets left in the house.
Okay, is Luke okay? You said Luke was there with him?
Luke was there, but I told Luke, okay. I went over to Granddad's house and I told Luke to go back to my house, and I called my daughter, and my daughter has come over and she's with Luke at my house, but I'm in Dad's house right now.
Okay. Now, Margie, is there anything else you can tell me that may have led up to this?
Well, I mean, Dad's always quirky. We've talked about that before, but let me think. Last Thursday, I was having lunch with him at his house, and the guys from Centerpoint were working on the transformer in the backyard, and he seemed really agitated that they were, you know, up on the power lines, and he kept watching them through the window. But that's really the only thing that I think could have upset him.
Okay, anything else you think would be beneficial for me to know what maybe have caused all this?
What do you think? Well, you know, Friday he came over for lunch, and it just wasn't like him. I mean, you know, Dad is very vain, and he never leaves the house without his hair combed and looking perfectly manicured, but he had his shirt on inside out, and his shoes didn't match, but I just played it off because, you know, his vision isn't that good anymore, and his shoes are the same style, they just happen to be dark blue and black, so I could see where he could have mixed up the shoes, but you know, now that I think of it, that's not like Dad. He never leaves the house looking disheveled.
Margie, is there anything else you can think that maybe has been odd or exceptionally quirky, as you put it?
You know, Saturday, he called me in the morning, and he said to get him some more Eskimo pies, and I thought, wow, I just bought him 2 boxes on Wednesday. So I went to the grocery store, and when I was putting his groceries away, all the groceries were in there, but I did notice that all the Eskimo pies were gone.
Okay. Now, Margie, I want to ask you a few questions because I don't have Bill's medical record with me right now. Have we ever diagnosed Bill with a definite mental illness other than the dementia that we've talked about?
No. I mean, Dad's always been very articulate and centered and caring and compassionate. I mean, we've never discussed anything mentally ill about him.
Okay. What about, has he talked about suicide or hurting himself or others in the past or even now, currently?
Well, no, not in the past, but Luke did say that if those spacemen come in the house, he's going to shoot them. And that would be okay because he'd protect us, which is why he wanted me to come over right away. Dr. Grumbles, I don't know what to do. I mean, a couple weeks ago, he locked himself in the bedroom, and I could hear him talking to someone. So I thought maybe a neighbor had come over, and I knocked on the door, and he said, "What is it?" And I said, "Dad, come on out, and who's in there with you?" And he said, "No one's in here with me." And I said, "Well, Dad, who are you talking to?" And he said, "I'm not talking to anybody." And I said, "Okay, Dad, listen, I'm gonna make some brownies with chocolate icing, you know, the kind that you like." And that seemed to change his attitude, and I got him to come out. But he's not even talking to me through the door now. He's just yelling that we're gonna be okay because he's got his gun and he can protect us.
Okay, Margie, I think I've heard enough to make me very concerned that your dad needs more than just you or I trying to talk him down. I think we need to actually have him brought in to the emergency room to have our geri-psychiatrist evaluate him. This is a very major difference from what our baseline is.
But Dr. Grumbles, I feel like I'm betraying him. I feel like I'm just abandoning him. I mean, I don't know what to do. And I guess if you think that's what we have to do, that's okay. But I just feel, I don't want to do that if I don't have to. Maybe you could give me some ideas of things to say to him through the door. That might help.
Margie, now I've dealt with this many times with other families, and they have had the same concerns that you have. It's normal for someone to feel like when they have to get their loved one help, that they're somehow letting the loved one down. If he was having a heart attack, wouldn't you tell me to call 911 and get him to the emergency room?
Of course I would. Of course
Margie,
I would.
this is the same thing. This is an illness. This is a mental illness, and we need to go to the emergency room and get him assessed. Now let me tell you what we're going to do. Okay, I am going to get your dad's address, and I'm going to get your cell phone number, and I want you to give them to me very slowly so that I can write them down, okay? Now, where is your dad's house right now? Tell me the address.
1901 Pine.
1901 Pine.
Correct.
Here in Galveston.
Correct.
Okay, now, what phone are you calling me from? The number so that I can get back to you on this phone line.
It's 409-732-1515.
15732-1515. Okay, now, do you and you think Luke's safe at home with his mom?
Yes.
You're safe there with your dad?
Yes.
Okay, what I'm going to do is I'm going to call the Galveston County Mental Health Deputy. He's going to come out and help you talk your dad out of the room and assure him that you're safe, Luke's safe, and that he's going to be safe, that Bill's going to be safe too. Okay? As soon as I finish talking to the deputy and he's on his way, I'm going to call you back and I will stay on the phone with you until he gets there so that we know everything's all right. Okay?
Okay, Dr. Grumbles, I did remember one more thing.
Mm-hmm.
Sunday morning when I called him to go to church, he didn't want to go to church because he said he hadn't slept well Saturday night and he just wanted to stay in bed. But when I went over there Sunday afternoon, he had a good, healthy appetite. He was watching TV, even doing a crossword puzzle. So he's still in there, Dr. Grumbles. I know he's okay.
Yes. No, he's okay. We're just having an exacerbation of the illness. And with proper medical care and psychiatric care, we're going to get Bill back to where he was. Okay?
All right, so let me see if I just heard you correctly. You're going to call the mental health deputy and he's going to come here to the house.
Yes, ma'am.
Okay, well, how many will he be? Will it just be one person?
It will be 1 or 2 people.
Okay. Should I tell my dad that someone's coming?
No, not right now. You just keep reassuring your dad that you're okay and that he's okay and that you don't think the spacemen are anywhere near the house right now.
Okay.
And just keep trying to calm him down until the mental health deputy can get there.
How long do you think that'll be?
It's an emergency 911 type call, so they will be there within a matter of about 15 minutes.
Oh my God. Okay. All right. Thank you, Dr. Grumbles. And you said you'd call me back?
I will call you back as soon as I hang up with the mental health deputy.
Okay. Dad, just a minute. Okay, Dr. Grumbles. Thank you.
Okay, hold on, Margie. We're going to do what we need for him and for you both, okay?
Thank you.
All right.
Okay, bye.
Okay, one of the important things that you do when you're trying to do these crisis mental health screens is active listening. If you notice, I kept encouraging her to tell me more. I didn't stop and say, is he threatening to commit suicide? Okay, did he sleep last night? What did he eat and when's the last meal? I didn't say any of those things. Those are the things we normally start bulleting off when we're thinking, oh, someone might be mentally ill or delirium or something going on. We start bulleting off these questions, and that's what we shouldn't do. What we should do is active listen, open-ended questions, getting them to tell their story. The one important thing about doing that is you want to make sure that it's safe. Because the issue is I asked her very early on, is she and Luke safe? If she said, no, I'm scared to death, Dad's going to shoot one of us by accident thinking we're a spaceman, I wouldn't have said, okay, well, tell me more. I would have said, I want you and Luke out of the house. Leave your dad. Get out of the house. I am calling 911 immediately. And that would have been it. But since I ascertained that I felt like they were safe and that Mr. Green was safe, I allowed the loved one to tell me the story. Now, there's a few specific questions that we usually want to know from the loved one. One is, has the individual threatened to attempt or use violence, acted dangerously towards others or self? Once again, very important early on in the conversation, you have to discern whether they are safe or not safe, because it's an algorithm. If they're not safe, you hang up, you call 911, okay? If they're safe, you continue to get information to see whether this is an appropriate call to the mental health officer or to the MHMR. Another thing is, has the individual threatened or attempted suicide presently or in the past? Once you threaten to attempt suicide, even in the past, you are more likely to threaten and to carry it out in the future. So that's an important thing that we need to know. Has the individual been neglecting personal care or body functions? Well, with my active listening, I know that. He's disheveled. She told me that during my active listening. Has the individual recently suffered a traumatic experience? We didn't go there, but that's something else. Loss of a spouse, loss of a pet. Sometimes just the friction of family dynamics can be stressful enough to push someone into a mental illness exacerbation. Does the individual have a history of mental illness? And lastly, does the individual take medications or have any physical handicapping condition? That I didn't have to go into because I'm his PCP. I know what's going on with that. But those are the important questions that you need to keep in your back of your mind, that as the loved one is reporting this instance to you, you are listening for those answers, and if they don't give you the answers, then you're going to go back and ask those specific questions. It's very important to make sure that you get the correct phone contact of the loved one and the address of where the distressed individual is located. Extremely important, okay? I can't tell you how important it is because I've actually made that mistake. I've been on the phone and the loved one, and I'm like, okay, I need the address so I can get the mental health deputy out there. Well, I got the address of the daughter who lives 3 blocks down the street. And the patient that the mental health deputy needs to be seen was down around the street and around the corner. So it's very important to be very clear. You need the address of the distressed person, not the address of who's on the telephone trying to get you to get them some help. I always make sure and get the distressed loved one's phone number because 15 minutes feels like 3 hours in that type of crisis situation. So my return phone call saying, I made contact with Sergeant Kevin Walker. He's walking out of the sheriff's office right now. He will be there within 15 minutes. Do you want me to stay on the phone with you until he gets there? That kind of assurance will keep the loved one calm and focused. It also gives them a lifeline because if something deteriorates in that home situation, they have you on the other end. You know, if something happened that he had found a bullet and she didn't know about it, and all of a sudden she hears a gunshot go off in the bathroom, I know immediately, okay, I'm calling 911. We're activating any squad car that's in the area to come to that house, not waiting for the mental health deputy to drive across town to get there. So calling them back takes a little time, but it provides a lifeline emotionally for the distraught loved one, as well as giving you a chance to make sure that things are remaining safe until the appropriate mental health deputy gets there to take over appropriately. The previous slide's information that we began going over, that's all kind of stuff that the mental health deputy, he's better to assess, and he will develop his initial plan with that initial contact. You know, I'm going to be able to give him a concise synopsis of what's been going on, and then he's going to use that information to help him prepare himself for when he goes into that home to know who he's going to talk to, how he's going to talk to, what he's going to talk about. Now, in those situations, there's sometimes when I go, you know, I don't think the mental health deputy is going to pick this guy up. This happened the other day with a patient that the family was frantic, things were a mess, and the family finally called 911, and the Texas City Police came out, and I knew the Texas City Police were not going to do one thing. They were going to say, this is a family problem. Call your doctor tomorrow morning. We don't want to get in the middle of this, you know. But the issue is, if you're concerned, if there's any concern at all, you or the family need to call and ask for help and let these mental health deputies and these peace officers that are trained to assess these situations make the final decision whether they need to transport them for medical attention or whether they can talk them down and just calm the situation down. If there's any concern at all, you call. You heard that from Sergeant Walker. What did he tell you? I don't know whether to call APS or call you. He said, like, call us, because we're going to figure out who to call. You call us. We will figure out what needs to be done. That's the type of attitude you need to take when you think there's a possible crisis. Get hold of the appropriate people so they can make those decisions. Now, we're not going to play the second scenario because that was actually me talking to Sergeant Walker, reporting it. So what had happened is I would call Sergeant Walker. I would tell him a very quick 2-minute synopsis about what's going on. I would tell him that I'm getting together the patient's medical records and the medication list, that I'm going to go ahead and get them ready to get them over to the Mainland Medical Center ER because I feel very confident that he's going to pick Mr. Green up and have him transported to Mainland Medical Center ER for evaluation. Now, what I do is make sure I get very concise, because I've just told Margie here, we're going to get somebody out there in 15 minutes. If I keep Sergeant Walker on the phone for 15 minutes, how long is it going to take him to get out to Margie Evans' house? And she's distraught. So concise is very, very important. And those 6 questions, was there any prior mental illness? Is there any violence going on? Is there unsafe behavior? You know, is there anything that triggered it? Those 6 questions that I had listed, those are the most important things that he needs to know. So if you can get the answer for those 6 questions with a very brief 1 to 2 minute summary about what's going on, within 3 to 4 minutes you've given him everything he needs to know, and he's in that car and he's on the way to the home. Now, you're off the hook now as a healthcare professional. Okay, you've gotten the mental health deputy, they're there now, but what's really going to go on with that distraught individual that you think is mentally ill? Well, what we're going to do now is play out another scenario with Dr. Emery and with Margie Evans. And we now have Bill Green at the emergency room. He's been evaluated. He didn't want to stay, but the mental health deputy and Dr. Emery decided an emergency admission detention was necessary, that she needed to keep this patient for at least 24 hours for her to evaluate his mental illness and his status. And so she's now going to be answering Margie's questions about what's going on with them locking Dad up in the mental hospital.
Ms. Evans, my name is Lee Emery. I'm one of the psychiatrists here at Mainland Medical Center. And we've been evaluating your dad. He seems to be medically stable. There seems to be no acute medical problem, to explain some of the things we've heard about. We really think he needs to be admitted to the mental health unit for assessment. He's not voluntary, so we're going to have to start what's called the first part of a commitment process.
How long will he be gone?
You know, it really depends. The average length of stay in our facility is about 10 days.
Does he know this?
He's been told this. I don't know what he really comprehended, though.
Will I be able to visit him?
Yes, of course you will.
Can I see him today?
He's here in the emergency room. We're bringing him over shortly. Yes, you can.
Okay. Can I go with him?
Yes.
Will he be by himself, or will he be like in a ward with all sorts of people screaming and carrying on?
Well, our mental health unit has some interesting patients, okay? And sometimes there is some hollering and carrying on. But most of the time, our patients are interacting pretty successfully.
But he won't be in any danger. No one can hurt him.
No, I don't think so. We'll have nursing intervention and nursing looking after him. And
So what if we go through with this and tomorrow morning he's perfectly fine and not talking about the spaceman anymore? Does he get to come home?
you know, in our experience, we really need to do an evaluation, which takes several days. What I try to do after during the first 24 hours is get my patients to agree to sign in, consent for voluntary admission and treatment, so we can do all that's necessary to evaluate their memory, their medical problems, and things like that. And most of our patients really do. They may have come in under that EAD warrant, which allows them to be brought to the hospital without signing in voluntarily. But what we try to do within the next 24 to 48 hours is get them to sign in, okay?
Is he still mad at me?
I don't know the answer to that question.
He was furious. He was so angry when the mental health deputy came. I mean, the look on his face, I don't know, how I'm going to get over that.
Well, being brought to the emergency room and going through all that he's gone through, most of our patients are pretty hyper that first. But the next day, after they've slept that night, they're usually more accessible to talking and being evaluated. And we explain to them what we're concerned about. And for the most part, our patients do sign in. Now, there are some that don't. And that's the group that we have to proceed with thinking about a commitment.
So is that something that I have to sign?
No.
Okay.
No, your doctors do that.
Okay.
It takes 2 physicians to proceed on with the commitment process.
So what else do I need to do?
Just visit, be supportive, listen to him. That's all you really need to do.
And you think he'll be able to come home?
We really need time to assess things. Work with his PCP, make sure that, how psychologically stable he is and what the dementia is, how bad it is, what we can do about treating it. Has it been treated with anything at this point?
No, and this just happened so quickly. I mean, he
Really?
seemed fine, just, well,
There's been no subtle, slow,
no, you're right. Right, I told Dr. Grumbles that 2 weeks ago I really thought he was talking to another person in his bedroom. I mean, he was having a conversation. I couldn't hear the other person talking, but he was having a conversation. He'd say something and then he'd respond with the next piece of it. But again, I got him to come out of the bedroom that time, but I couldn't get him to come out of the bathroom when he was going on and on about the space aliens.
Is there any history of mental illness?
No, there isn't. There isn't. But the more I think of it,
Yeah.
he has seemed very preoccupied sometimes when I'm talking to him. I mean, sometimes Dad doesn't pay attention to what I'm saying anyway because he thinks I'm just a babbling woman. But lately, he hasn't even been interested in what Luke's telling him, and he's always been interested in his grandson.
So there have been some changes.
I guess so.
We need to understand what's going on, or try to understand.
Okay, all right. So you think I can see him soon?
Yes.
All right. Okay, thank you.
Dr. Emery is going to kind of walk you through now the legal process that we go through when we have these patients brought into the emergency and they're detained for 24 hours, what she does then as time goes on.
What we have to do is fill out a physician certificate for commitment and turn that into the probate court, reflecting our ideas that this person really has a major mental illness, maybe it's a dementia, maybe it's a psychotic depression, that the patient has not agreed to be a voluntary member of in our hospital. So we have to get that paperwork done, work with the probate court, and get ready for a hearing. There are 2 hearings. Let's see, what is this? The first hearing is with my magistrate, Mr. Shattuck. He comes in along with a court-appointed attorney and the district attorney. And they review my records, they talk to the patient, and they have a hearing about whether or not it's valid to proceed on with a commitment hearing, okay? We have 14 days total to do that, but really it happens within the next week. Now sometimes if things are getting better, we don't go on with a commitment, we just kind of hold things and things get better, things like that. But if things are really pretty intense and we have to go on with a commitment, then we have a court hearing with Judge Kimberly Sullivan. And at that final hearing, I have to give testimony under oath about what's been going on with the patient and why I think the patient needs to be held against the hospital against their will. So, okay. Let's see, what else is there? Minutes of hearing. Everything happens usually within 14
Yeah,
days.
14
Yeah.
days is usually.
And the commitment hearing is only for 90 days, no more. And the other thing that can happen, if they are committed and then they're not discharged, if they get medically stabilized, then they will be furloughed home. This happened last fall, and this particular person didn't follow up with her medications. She didn't follow up to come back and see me. She was on furlough, and she fell apart. She deteriorated. So at that point, we brought the furlough back, and we transferred her to the Austin State Hospital. That's very rare, but that does happen as a way of keeping that person under the opportunity of treatment, helping to get them stabilized. But most of the people that go to the Austin State Hospital don't stay 90 days anymore either. It's a very brief hospital stay of 2 to 4 weeks. So, but in our hospital, the average length of stay is 10 days. Okay, what else?
So let's kind of open it up to questions now.
Well, one of my old concerns, and I think from the general discussion, things have changed over time, but it used to be that the psychiatric hospitals could not treat someone where there was not a diagnosis of a mental illness. That if all we had was dementia and behaviors custom with dementia, but that were hazardous, that it was sometimes difficult to get them the mental health care that they needed. So if I have a patient, I have a son who calls me and says, "Dad hit me last night," or last week, and it's kind of a two-stage question, is does it have to be immediate? You know, how far ago? Because a lot of times families won't call me until 3 or 4 days later, I woke up, my husband was standing over me with a knife. The dad pushed me down the stairs. So I've got those issues, but I hear about them too late to really do an immediate intervention. But it sounds like that I can, when all we have is dementia, that there may be a mental illness that has not yet been diagnosed.
We use the term
Then it's
dementia
okay.
with psychosis many times
Okay.
because that's what's going on. And they do
Okay.
need medication treatment for the psychotic processes. Whether or not we can help with the dementia, that's another challenge.
Okay.
Okay. But that's not
Right.
gonna,
Okay. And, yeah, I hear a week later, Dad pushed me down the stairs, and I tell him, oh no, you don't tolerate that behavior. The next time it happens, you dial 911, or the next time you're fearful, Dad's gonna push you down the stairs or do something else, dial 911 and talk to the mental health deputy.
if someone's being that aggressive, we have to try to change that.
Okay, so even if it's 4 or 5 days later, the behavior
If it's
is
an-
gone.
It's probably gonna happen again.
Okay,
You know,
so they should
it's
come
just
on
a-
over.
Once again, the issue is if you feel like there's danger or a crisis, it is not in your practice scope to decide whether it is a problem that needs medical intervention. You activate the evaluation process. And that's what we've been talking about today.
Bob, do you want to say anything about what, because you support me a lot, but you also make me,
You know, when she's raised, we could talk about her situation all afternoon, but get a lot of things there. But maybe we could say to start out that, I think dementia may be on that list of mental illnesses. So I think that answers the first question.
okay.
It may not have been, I think it's there now. So when I fill these forms out, before you have any commitment at all, you gotta have a mental illness diagnosis. You gotta have that. So oftentimes I write dementia, particularly in Dr. Emery's field, because she does mostly geriatric type, I think, situations. Anyway, so I just write down dementia, and as you said, that's a big word, but it covers something that's there, it's already diagnosed, and they can carry it forth if they want to. And of course, that's in the treatment area then. You had also said, the overt act. That's what they talk about, an overt act. Got to have done something that's dangerous to yourself or somebody else. And there's no time limit. But then there is. He pulled a knife on me 2 years ago. Well, I don't know what happened, but things been pretty good since. So I don't think that'd be an overt act. But he did it 2 days ago, or maybe 2 weeks ago. Yeah, you may want to look at that. And so there's no time limit in the statutory scheme of things, but it's there. And so you just got to kind of see what you got. And then, like I said, the criteria for all of these commitments, particularly probable cause, is that there's got to be an overt act that demonstrates itself into a risk of harm to self or others. And that's the kind of the judgment call we have to make. And I will say that my job's actually pretty easy because the cases we see are pretty well farther feathered out. I mean, there isn't a whole lot of guesswork left. I mean, something's going on. It just, thanks to the doc and all her hard work. Now, I will say on Dr. Emery's field, a little more subtlety there. We're talking about people that are 80 plus years old. I mean, they don't run around with guns and knives, and if there's something wrong. We hear about banging wheelchairs into each other and swinging canes that hit you up the side of the head. I mean, I guess that's the gun and knife after 80 or something. I don't know.
The nursing home weapon of choice.
Someone's going to get hurt. And so that's the kind of thing we're looking at. But then, you say, well, look, we can't send this 85-year-old lady to Austin. I mean, I've been to Austin State Hospital as a visitor. I've never walked the wards. I don't know what it's like, but I hear stories. I'm told it's probably not where you want to send an 85-year-old lady. So rarely does anybody leave Dr. Emery's care, but they do leave and go someplace. So placement is another big issue that her and her staff spend an immense amount of time trying to find a place for these people to go. They had a fight at the nursing home. He ran the wheelchair and hit so-and-so upside and does it all the time. We've had to bring him over here, get him quieted down. But now, the nursing home doesn't want him back because he's done that 4 or 5 times. And now, Dr. Emery has a house like everybody else, but she doesn't have any spare rooms, so now she gotta go find a place for him to go.
Well, one of the things we're trying to do with the Institute for Living is people call us and bring in their family member that's having some emotional problems.
Right.
And we see them as an outpatient and try to start some kind of rapport, some kind of effort to establish what's been going on. So we do have an outpatient evaluation. We don't like to send people to the emergency room unless it really is an emergency. Okay?
I'd like to just see if there's any questions for Dr. Emery or for Bob Shattuck from the off-campus sites. No?
I have a question. In a crisis situation like this, even when the deputy goes out there and they take them into Mainland Hospital, do they have to qualify in terms of insurance or funding, or is that question never asked? Is that not important, or are some people turned away because of that?
No, our unit, we have some restrictions. They have to be at least 62 years of age. Our inpatient senior care unit, they have to be that old. Or whether they have Medicare, managed Medicare. And we have had some charity patients, so if they need to be admitted, they're admitted.
But then when does that change, or does that change? Like, does that change after 24 hours? Does
No.
that affect
We
your
try to get
intervention
each person
at all?
stabilized with the best we can.
And would that person, even without any type of funding, could they even stay for the 10 days or whatever that you were talking
They
about?
have, yes, they have.
Well, I'd very much like to thank Sergeant Kevin Walker and Dr. Lee Emery and Bob Shattuck for coming to help us today, because this is a topic that lots of people have limited exposure with, and when you do have a problem, you need to know something right away. So the last thing I'd like to do before I turn it back over to Tony is I'm going to post the slide that has your contact numbers for your area MHMR or mental health deputy contact. Okay, for each one of the area, teleconferencing area, as you can see, I've taken and called and researched around to find who it is that you contact, whether it's your sheriff's department, whether it's your MHMR 24-hour hotline. These are the numbers that will be monitored 24 hours a day for you to report and discuss any mental health crises that you need to see about getting evaluation and activation of mental health services. All right, I'm going to turn everything over to Tony now.
I'd like to thank Lee for putting this together. That was really super